Hi.
Hi.
Good.
Hi, everyone.
74 people have joined. Exciting. I will start with my slides. So I am Rashmi Sinha. I founded the Systemic JIA Foundation in 2015. This is the agenda for today. So first of all, who's here today? So let's go over. We have 112 registrations last we checked from 16 countries in Europe. And you can see where we have people registered from and where we don't and where we have work to do. You can see sizable, kind of group of people from Italy, from Germany, from Czech Republic, from Netherlands, and then from many other countries. And we also are joined by one person in India, three in the USA, and one in Brazil. So that's who we all are. We are not just patients, there's so we have several physicians joining us, and thank you for that. We realized later that we should have explicitly an option for physicians to join. We just hadn't thought that. We don't have just parents joining. There's 25 adult patients. So there's a large group of adult patients from Germany specifically. I think it was circulated in a German adult stills group. And the rest are caregivers. So we are glad to have everyone with us, and especially the adult patients too. Going on a little bit about the foundation, I'll try to keep it brief. It was founded by parents of a systemic patient with systemic GIA and MAS. My son, who was diagnosed in 2015, and when we realized that there wasn't really a foundation like this which existed, then we got to work, and I started attending scientific conferences and met many of the doctors. And actually, in June 2015, I went to ULAR and I met several of the doctors. So many of the people who are joining us today, we've known them for many years, for a decade or so, and worked together. Some of the things we do is that we help patients directly. There is a very good systemic JIA parents network on Facebook that we work closely with, and please join that if you want to talk to other patients' parents. We've organized several conferences, both patient conferences and research conferences. We raise funds to fund research projects in both US and Europe. This is our first specific event for Europe, and we hope to build upon this a lot more. As I was mentioning, we are all over the world. We are, we've started in the US. We hope to work more and more in Europe now, and then hopefully moving on to Asia, where some countries we have very good contacts, and South America, where Luciana is laying the groundwork. So we are an international organization. A quick mention about some of the patient resources on our website, and you can use this QR code to grab the URL if you would like. We have a disease brochure that we are working on translating into other languages. You can find out about accommodations in school. You can join the patients network. I really encourage you to join. It takes 10 minutes, and then we have about 500 patients in our database, and it's very helpful to have more and understand the disease in different parts of the world. So, talking a little bit about our involvement with Europe, even though it's not been, we haven't had Europe specific conferences, but we've actually have very good relationships with doctors in Europe from the beginning, and have started working with patients more now. And we have had booths at the press conference and plan to do that again this year. We've been interacting with, in one way or the other, with the European Medicines Agency since 2016, where someone from the agency attended our conference, and since then we hope to increase our work with them as well. We help support European research projects, and all this, and hopefully grow on this. And you can see in these photos that this is the second photo at the bottom is that two of the patients, at our last year's conference here are from Europe, and if you see the photo with the whole group, you'll recognize several people there. This event has been organized working with the press, their SJIA MAS working party. And I just want to just make sure to mention them, and so that you know about the group. And they are they've organized kind of many of the countries in Europe together with this working party with experts from all over Europe. And it's been really a joy working with them. Specifically, we have 4 members of the core group of the working party who are joining us and who will be in our speakers panel, who are Dr. Claudia Bracaglia, Dr. Francesca Minoia, Dr. Vastert, and Dr. Christoph Kessel. We are also joined by several other physicians and SJIA experts, and we want to acknowledge them and make sure to say that they're very welcome to speak up when you want. With that, I'm going to move on to the patient voices session, and I'm going to hand it over to Luciana for this. And I stuck to time, so.
So now we are going to start the patient voices session. Normally in our sessions or in our events, we always have time for people to speak up, for the patients to tell their stories, and we selected different patients with different phenotypes, because it's important for everyone to listen what is happening in different countries and in different ages too. So the next slide, please, Hashmi. So with that, I'm going to ask Giorgia and Fabio. They are from Italy, and they are going to talk a little bit about Azzurra. It's their daughter, and about the diagnosis and the disease course. So Fabio and Giorgia, are you there?
Yes, yeah, we are. Good morning, good afternoon to everybody, wherever you stay in the world. Thanks to give us this opportunity for all of them involved in this still disease. I introduce myself. I'm Fabio, and Giorgia is my wife. We are the parents of Azzurra, 12 years old. Diagnosis of Azzurra was the first episode in March 2017, with the first warning of gastroenteritis, and based on fever for weeks until the April, the first episode of HLH, based on what the doctors realized after 19 of dark days, wherever nobody knows about the different aspect of the disease of Azzurra. They tried with different therapies, first of all based on cortisone therapies, but the problem was the low level of blood exams, in particular the platelets and the ferritina very, very high. Fortunately, after this dark period, we arrived to May 2017, where Azzurra was recruited in experimental protocol, clinical protocol, and she took the emapalumab for the first time. And we can say after the second infusion, she tried, and she started to respond until after the first 2 weeks, we saw the first improvements in terms of bloody levels exams. Until this the emapalumab, let's say, it was a miracle for Azzurra at the very end, because we continues with the drug until August 2017, and after that period, even if the HLH was, let's say, under control, she continues to have persistent fever. And there was a suspicious that the HLH was behind the corner again until the end of October 2018. Unfortunately, in the February 2020, after another gastroenterology episode, and after a few fever episodes with high fever, continuously in more than 1 week, she has another bad episode with a high triglyceride transaminases and all the blood levels out of control. Based on what in the 2017 succeeded, thanks to the immediate reaction of our team of doctors in the rheumatology department in the Ospedale Bambino Gesù, on March 2020, they realized the reactivation of this disease, the still, and they fortunately obtained to start it again with the emapalumab combined with an antibiotic therapy. Was not enough to understand if Azzurra was in the right direction, and with the help also of the oncohematology department, we received the opportunity to have the bone marrow analysis for three times. After that, the result was good. Azzurra responded, let's say, well, and we continue to use the emapalumab until in 2025.
No, 21.
No, sorry, in 2021, switch with another two drugs, the anakinra and then the cananinumab drugs. After this period were always under control with the continuous day hospital, periodic day hospital, they decided to use the MAS 825. And we started with this experimental drug again in June 2022. Actually, Azzurra continues to use the MAS 825 every 5 weeks. Thanks to this drug, she's under control, let's say, even if every 5 weeks she needs to receive an evaluation from the equipe, from the doctor's team. And we can say that is under control, but especially is not active, let's say. Actually, she has not any symptoms that can active, let's say. This thanks to the big effort of all our doctors in Rome, and also thanks to these experimental drugs. Even if are experimental, we really hope that one day we can have on board all these miracles drugs for everybody. I think it's enough because the time is over, if I'm not wrong. And please, me and George are available to everybody, with everybody, to answer to any question you can have. We have also our mail or whenever you need. Thanks for our attention.
Thank you, Fabio and Georgia, and thank you for keeping the time. Fabio, I know this is a really almost impossible task, so really thank you. But thank you for sharing the story. I think it's really important for us to understand what everyone is going through. And the doctors will also talk about this drug because some people here, maybe they have not heard about the MAS 825, then the doctors will talk about this and about the clinical trial. So can you put the next slide, please, Jasmin? So now we are going to Austria, to Vienna, to talk with Maria and Andreas, and they will talk a little bit about Jasmin, their daughter, who is 15 years old. So are you there, Maria and Andreas?
Yes.
Okay.
Yes.
Hi.
So
thank you for sharing.
You're welcome. So my name is Maria, and this is my husband Andreas, and we are located in Austria, in the capital, in Vienna. And I emphasize this because we are very lucky that we have two big hospitals and who have special centers, and so Jasmin was diagnosed really quickly. This is why I started with this. It started 10 years ago when Jasmin was 5 years old. She had fever, rash, joint pain, and she was admitted to a small hospital first. And even there, they right away suspected that this could be juvenile arthritis. And they referred us to another bigger hospital. And there they did tests and they took the inflammation markers, and the lab showed a very high calprotectin. And so the doctor started right away with Kineret and steroids. And it seemed to work well for the systemic features, symptoms, but she developed massive polyarthritis. So all her joints are affected, even today. And so the Kineret wasn't working as good as it should have. And then we tried all the known meds like the Kineret, then Roactemra, the Ilaris, Xelians, cyclosporine, methotrexate, thalidomide. I mean, everything we could get. And none of them showed the success we were hoping for on its own. And because of that, we had to increase the steroids, and she got oral steroids and she got IV steroids. And therefore, she developed the Cushing syndrome. And it also caused her to have the vertebral compression fractures, multiple, and also a very serious hip necrosis, which is still it's getting better now, but it's one of her main issues till today. And
Heart problem.
yeah, I mean, all the side effects of the steroids you can have, she had. So that's when the doctor decided to start to combine two biologics, the Kineret and the Roactemra. And that seemed to work well, but still not good enough. So we added the Xelians. So now she's on two biologics and one JAK inhibitor. And this is the combination that worked best for us until now. So last year we switched the Kineret to Ilaris so that she wouldn't have to have the daily injections. Now she can have the monthly injection. Yeah, so also to support her immune system, she gets the immunoglobulins monthly, which we can administer at home. And also she has to take antibiotics to prevent lung infections. And yeah, I think that's our story short. We are very happy that she has no lung involvement. We will check it later this month, but so far no lung involvement and also no eye involvement. It's mainly the polyarthritis. Yeah. So that's our story.
Okay. Yeah. And also thank you for making the long story short, because
Yes.
I know it's again, it's really almost impossible. We have here like 15 years being like you told in 5 minutes. So thank you.
Yes.
And thank you for
And
sharing.
for all you, you're heavy welcome. If you have any questions, do it here or in the chat or by email. So it's no problem for us sharing our story in detail.
Okay. Okay. So with that, we are going to the next story, which is Antonia. Can you please, the next slide, Hashmi? So Antonia's daughter, Isobel, she's 17 years old, and Antonia and Isobel, they are in the UK. And Antonia will tell us a little bit about the story, which has been a long story too. So Antonia, are you there?
I am. Hi.
Yeah, hi again.
Hi. Hi, everyone. So Isobel was diagnosed in June of 2019 after a couple of months of symptoms. Her diagnosis came because her ferritin was so high. You can see from the slide, 35,000. So she was very quickly put onto a high dose of steroids and then weaned off. Those of you who are in the UK may know I was under the care of a local hospital, but we were also put under Bristol Children's Hospital. So we because we're down in Devon. So we spent time in Bristol Children's Hospital. She was then sent away, high dose of steroids on a weaning dose to see what happened after that. And her flare came back, her ferritin increased. So she started on tocilizumab, which didn't work. She was permanently itching, permanently rashy and unwell. So 12 months later, we were moved back to Bristol again, and she started on anakinra. Within 3 months, she still wasn't well. She had 2 rounds of IVIG in October, December. She had COVID, and that brought a lot of stuff to the surface again. And by December of that year, she was incredibly jaundiced, very breathless, and just surviving, but only just, really, it felt like. So at that point, we here at home and her doctors in Plymouth didn't feel that she was getting the best level of care. So we asked for a second opinion. I don't think this is something that's done very often, but it was something that we felt that we needed to do, and we were put under the care of a different doctor here in the UK in Bristol, and he pushed baricitinib. So it turned out that the anakinra she had a negative reaction in her liver, and we think it also caused interstitial lung disease. So she was put on oxygen, weaned off the anakinra, and then when her liver was back to normal, we were able to start baricitinib. And at that point, we saw her improve month on month. Baricitinib's not used a great deal here in the UK. It's on trial. I know that some people have got along really well with it and others have not. So within 3 months of her starting on the baricitinib, she was off oxygen during the day, only on oxygen at night. And by the end of August of that year, she came off oxygen completely, which we didn't think was going to happen. We were prepared for the fact that she'd be on oxygen for the rest of her life. So that was the last big hurdle, really. She just improved sort of month on month. We had a few small issues around her exams and important kind of those stressful times of her life. But generally, all was well. And for the past 12 months, she's clinically well. She's now 17. She did that typical thing of feeling well. So she basically weaned herself off her medication without us really knowing. And at the moment, she is symptom-free and drug-free. She's in unmedicated remission since March. So she's transitioning to adult rheumatology in June after her 18th birthday. And we've started that transition now. That in itself is uncomfortable, I think, for us, having been under the care of Professor Ramnam in Bristol and Dr. Olsen down here in Devon. It's an uncomfortable position that we're in to move away and into adult care because it's so different. But it's another hurdle that we're crossing, and we're very, very happy to be doing it, to be seeing her, and for her to be living into adulthood is not something we necessarily thought that we would see. So it's a good thing and a bad thing, and that's a very short rundown of our story.
Thank you, Antonia, for sharing. And I do relate with you because we stopped having SJIA problems, and we start having like young adults or adults being trained problems, let's say this way. And we also encourage everyone who wants to share their story, or if they want to send us emails, if they want to share in other events that we have, or even now we'll have time at the end of the session for you to share your story, especially the adults patients. Sometimes it's hard for us to get adults to tell their story, and we are really open to hear and to try to collaborate with all of you. So with that, we end up the patient stories part, and then
we have a little bit of time.
We
have a few minutes. So
Okay.
we'd love to hear from some other patients. Please speak up if you feel there's, things you want to share. This is about your voices, and you can think of these stories as just getting the ball rolling. So please tell us, please share what you are thinking. We have a few minutes. And as Luciana said, it would be great to hear from any adult patients who are here. And if you're not comfortable speaking up, then please maybe type it in. Can I just ask someone? Catherine, I see you. Can I put you on the spot, please?
Yeah, what do you want to know? Should I tell our story, or
Yeah, just in
from
like
the
2
German
minutes, just
part?
tell us, how, like, where you've also had quite a journey, yeah.
Ja, first of all, herzlich willkommen alle Deutschen und Schweizer und Österreicher. Schön, dass ihr hier seid. I just welcomed the German part. Yeah, we have a daughter. She's now 6 years old, and she got diagnosed, I think when she was 7 months old. We live in Switzerland, and she also had quite a journey. We tried, I think, all the meds that were available in our country. Switzerland is a little bit different because it doesn't belong to the European Association. So sometimes we have the same meds, sometimes it's different. And then finally, it's now 2.5 years ago, we decided to go for a bone marrow transplant. We could do it in Zurich, where we live, and yeah, she's doing fine now. She's a kindergarten girl, and yeah, but I'm really happy that I found a foundation, and I'm also in the German Stills group, and always telling them it's great work what you do in the foundation, and we can all now I don't know the English word, profitieren, that we, yeah, it's very good for us in Europe that for all the things you do in the US, and that you work together with the German European doctors. Thank you.
And Catherine was funny because she posted in Facebook group, and I was living in Switzerland on the same center that her daughter was being treated. And then we just started talking, and and then at the end, her daughter went to bone marrow transplant, which my daughter did too, back in 2018. And we were able to meet in person. So that was a really
this was great. And also to say, Luciana's daughter was the first that did bone marrow transplantation in Zurich, and my girl was now the fourth that did that.
Yeah. I would also love to hear a little bit about the local organizations that is going on, starting with in Italy. And Sala, if I can just ask you to speak, sorry to call on you, but I think it's great that that there is in Italy, the patients have started meeting and organizing themselves, and that's great because the foundation can address the overall questions of the medicines, interact with EMA, but there's a lot of local issues that we will not be able to be that helpful. So we encourage you to connect with each other, and we will help in those connections. So Sala?
Yes, basically we've just started. I think we're about a month in at the moment. So we have a WhatsApp group that's our the first step that we've taken. And we've started to sort of look into what does it really take to make an association of like a serious level. But it's been great because for example, with my son, we've been dealing with this illness for 2 years, and I felt really lonely without any kind of organization or group to share your feelings or thoughts with. So it's been great to get to know other moms and other dads, other parents, family members that have been going through the same thing. So we're working on it, and it's something that really, really is needed, just for emotional support, and then for the support of coming up with new help for this kind of for this disease. So we're working on it. I would love to hear from anybody in other countries, because I've done a little research on the European level, and there's not a lot of organizations specifically dedicated to Still's disease. A lot of rheumatology organizations, but nothing sort of like on this level. So we have to move on with this one, because it's very specific, this one. It's not something that you can just deal with on a level of like all the rheum diseases. Excuse me. So
yes, the journey is quite different for Still's disease and for many other diseases.
Yeah.
I also really want to stop for a moment and talk about the adult patients, because when my son was first diagnosed and I started spending time, met all these other parents, at first we really thought of this as a kid's disease. Yeah. And then we started finding all these adult Still's patients in these Facebook groups and started joining those as well. And what we realized is that for many patients, they had the disease as a child, it went into remission, then it came back. And then there were the adult patients who got diagnosed in adulthood. And even biologically, we know that the disease with the children and the adults is really the same disease, with like the difference in 1 or 2 symptoms. So it's really important for us to work together with adult patients and to represent that community as well, because the problems and the solutions are the same. And in fact, I think the adults actually have a harder journey, because with the kids, at least the parents are there. It's easier to deal with somebody else's disease in helping them, but it's very difficult to help oneself. So my heart goes out to adult patients having to navigate this alone. And we have work to do as a foundation to be more helpful there. So I'm so glad that several of you have joined, and I hope you reach out to us after the event, and we can connect and better work with you. And if you want to share a story, we have a minute or two before going on to the next part of the session.
Me? No, or somebody else?
Anyone, if they want to share before we'll move on.
I just want to say before we move on, somebody has already written on the chat that they want to join our WhatsApp group. I'm gonna answer, I think, in public. So I'm gonna put my number in there. So people, if any Italians want to sort of join our group, feel free to text me and I'll add you in the group. Okay.
Okay, so let me go to my slides and share those again. So we'll move on to the next part of the session, which is the speakers. And I'm going to just actually go back to, I wish I had, here. So with that, we are going to hand it over to the SJIA MS Working Party from the press organization, starting with Claudia Bracaglia, who is going to start this off from the doctor's side. And Claudia, on to you now. You can share your screen.
Yeah, thank you very much. So good afternoon, everyone, and good morning. Okay, I'm starting first presenting bit the MAS SJIA Working Party of PRESS. So PRESS is the Pediatric Rheumatology European Society, and the MAS SJIA Working Party is a kind of working group in the context of the society who is focalized on MAS and SJIA. So the four of us who Rashmi already presented before are involved in the working party. I'm actually the chair. Francesca is the secretary, and she also leads the clinical care. And Christoph leads the science and research, and Bas the education and training. So we work together with the members of the working party in different projects. Right now, we have around 150 members who participate to the working party activities, and people come from 40 different countries and also come from non-European countries, because even the press is a European society, so there are a lot of other countries that are affiliated to the society. So the aim of the working party is to promote knowledge on SJIA, still disease, and MAS, and to foster translational research and international collaboration through experts in the field of these diseases. And we, of course, work to improve the care and the outcome of patients with still disease and MAS through harmonization of treatment, validation and biomarker, etc. So we have a different international clinical and translational project ongoing. We collaborate with some European partners, such as EULAR, that is the Association of Adult Rheumatologists, and the ERN-RITA network, that is the European Network for Rare Diseases. We also collaborate with non-European partners, in particular in the North America with the CARA, that is the Childhood Arthritis and Rheumatology Research Alliance. And we, of course, collaborate with patient representatives, in particular with the Systemic JIA Foundation. We also promote educational activities through organization of webinars, courses, and of a different level. So, and that's it on the working party. And now I move to my talk that is focused on the disease, to still disease and its complication, MAS. So starting to the beginning, still disease was first described from George Frederick Still, who was a physician and pathologist from UK, who first described in the 19th century 22 children with a special form of arthritis. And the name came from him, actually. So the disease has been also called systemic JIA, but now we are back to call it still disease as the adults, because it's the same disease. There is no differences between children and adults. So, but what is still disease? Actually, is an highly inflammatory disease that can affect in the same way male and female, and also in children of different ethnic backgrounds. The peak age of presentation is around 1 at 50 years of age in children, but as I said, there is the same disease in children and adult, and the name is the same. And MAS is the main complication of this disease. The clinical symptoms of still disease are typically fever, as you said in your history, is a typical pattern with spike above 39 once or twice a day, and characteristically the fever is in the late afternoon and evening, and chills are frequently during the fever. So children have also rash that is usually salmon, macular or maculopapular rash, but sometimes can be also urticarial, infiltrate, very pruritic rash. The rash is usually transient and also increased during the fever. Arthralgia and arthritis can be also present. Arthralgia is typically present at onset, is most common, while arthritis can first manifest later, and in the 30% of the patient there is no arthritis. And in fact, in the last guidelines for diagnosis of SJIA, arthritis is not mandatory for diagnosis. We can also have lymphadenopathy, that is an enlargement of lymph node in cervical, axillary, and inguinal areas. In 25% of the patient, the lymphadenopathy is present at onset and is usually symmetrical. The patient can also have hepatosplenomegaly, that is an enlargement of liver and spleen, and the hepatomegaly may be also accompanied by elevation in transaminases. And there are also serositis, that is an inflammation of serosa, of pericardium, pleura, and peritoneum that can be present in 15 to 20% of the patient. Pericarditis is the most common, and also the pleural effusion, while the presence of peritonitis is less frequent. So how we can diagnose Still's disease? Actually, it's not always so simple because there is no specific laboratory test that can help a clinician to do the diagnosis. So it's a kind of exclusion diagnosis. So we need to perform different exams to exclude other conditions to obtain the final diagnosis of Still's disease. So we need to also perform some exams like bone marrow aspirate or total body imaging, and also the biomarkers can help the clinician for the final diagnosis. So as I say, the differential diagnosis is very important. We need to exclude first infection, viral and bacterial infection. We need, of course, exclude malignancies, so hemato-oncological condition. And Kawasaki disease is another important disease that can be excluded, and sometimes patients with Still's disease received as first diagnosis the diagnosis of Kawasaki disease. This is quite common. We also need to exclude inflammatory bowel disease and other autoimmune or autoinflammatory conditions. Laboratory tests are not so specific. We usually can find a high number of neutrophils, and we can find also anemia, a high number of platelets, and also high level of biomarkers such as ESR, CRP, ferritin, D-dimer, and also IgG. Albumin can be low, and typically the autoantibodies are negative in patients with Still's disease. To the imaging, we need to perform chest X-ray, abdominal ultrasound, echocardiography, and as I said at the beginning, also a total body imaging that can be a CT scan or an MRI. The pathogenesis of Still's disease is still unclear. We know that both innate and adaptive immunity have a central role, and there is an overproduction of some innate immune factors, such as IL-1, IL-6, IL-18, and 600 proteins. And these factors are very important because they are responsible of the clinical manifestation of the disease. These factors are also the biomarkers of the disease. In fact, patients with Still's disease have high levels of IL-18 and 600 proteins, and these biomarkers, even not validated and cannot be measured in all centers, can sometimes help clinicians when available in diagnosis, because can help to distinguish Still's disease from other disorders with persistent fever, and also can be also useful in monitoring the disease to identify the risk of MIS, the response to treatment, and also to evaluate the disease course. Still's disease can have a different clinical course. Half of the patients have a monocyclic disease with a single phase lasting up to 24 months. Less than 10% of the patients, have a polycyclic course with several disease flares separated by months of inactive disease. And the other half of the patients had the persistent systemic inflammation and sometimes a progression of arthritis. So what about the treatment of Still's disease? At the beginning, when we are going, during the diagnostic workup, the treatment is with non-steroidal anti-inflammatory drugs. Then the glucocorticoids, intravenous or oral, are still commonly used, but we know that they are related with severe side effects, in particular in the long-term treatment. So many of the patients can develop severe side effects such as Cushingoid aspect, severe infection, stria rubra, hypertension, the osteoporosis, and also crash factors. So we have to avoid as much as possible treatment with glucocorticoid for long term. IL-1 and 6 inhibitors are the main treatment of Still's disease, and in the last 20 years, they completely changed the natural history of these patients. So we have two IL-1 inhibitors that are anakinra, that is IL-1 receptor antagonist that can be administered subcutaneously every day, and canakinumab, that is an anti-IL-1 beta monoclonal antibody, and it has been administered subcutaneously but monthly. And there are also L6 inhibitors. Actually, we have only one available, that is tocilizumab, that is an humanized monoclonal antibody, anti-L6 receptor, both soluble and membrane, that can be administered every 2 weeks. There is also the sarilumab, that is a fully human monoclonal antibody, but is not yet available because the dose-finding study is still ongoing. The recent recommendation on treatment for celiac disease underline the importance of start the L1 and 6 inhibitor as soon as possible once the diagnosis is established. And also the glucocorticoid, even our efficacy, need to be avoided, especially for the long-term treatment. And which is the complication of celiac disease? As you know, as the majority of you know, MAS is a severe complication of celiac disease. It's a complication of other rheumatic disease, but it's most common in celiac disease. It is an hyperinflammatory condition, and it is caused by an uncontrolled activation and proliferation of T lymphocytes and macrophages. And these cells growing very fast during the active phase of the complication. These hungry macrophages produce a large amount of cytokines, in particular interferon gamma, that is considered the main cytokine of MAS, and they hit blood cells. And in this way, they are responsible of the clinical and laboratory manifestation of MAS. So patients with MAS usually have an abrupt onset, sometimes very severe, with a rapid progressive evolution. Symptoms are typically fever, again, symptoms that are the same of celiac disease, such as hepatosplenomegaly, lymphadenomegaly, but they can also have bleeding, such as purpura, ecchymosis, or mucosal bleeding, CNS involvement, up to multi-organ failure. From the laboratory features, MAS can have cytopenia with low platelet count, low white blood cells, anemia, also hepatic dysfunction with increased levels of transaminase. There is a coagulopathy, high levels of LDH and triglycerides, low level of sodium and albumin, elevated levels of ferritin and CRP. And ferritin is the very important features of MAS because hyperferritinemia is a hallmark of MAS. So all patients with MAS have elevated ferritin levels, and if there is a suspicion of MAS, ferritin should be measured again and over time. As I said, also in MAS there are biomarkers available, IL-18 that is available also for celiac disease, and in particular CXCL9 that is a chemokine induced by interferon gamma. And again, these biomarkers can be very useful for disease diagnosis and for monitoring patients with MAS. MAS can be present during the disease course, so once the patient has already received the diagnosis of celiac disease can develop MAS, can be also present at onset, and in this case can be more difficult to have the diagnosis. And there are also patients with celiac disease that can have chronic relapsing episode of MAS during the disease course. Regarding the treatment, of course, glucocorticoids remain the main treatment of MAS, particularly at onset when the evolution is very severe and rapid. So we need to use a high dose of IV glucocorticoids. Cyclosporine is the second treatment that we usually use in patients with MAS. And we also can use IL-1 inhibitor, in particular anakinra, intravenous at high dose compared to the dose that we usually use for treat celiac disease. We can also add immunoglobulin, and in some cases, some chemotherapy, such as etoposide, can be used in very severe cases of MAS. But of course, as this drug is a chemotherapy, can have a serious side effect. But there is one drug that changed the history of MAS, that is emapalumab. Emapalumab is a fully human anti-interferon gamma monoclonal antibody that can bind free and receptor-bound interferon gamma The drug has been studied in a different trial, and in the last June 2025 in US, it was approved from FDA for patients with MAS in the context of still disease, children and adults. And we hopefully are waiting for the approval also in Europe. And this drug is very useful, and Francesca will explain more about this. So to conclude, still disease is a highly inflammatory condition. The pathogenesis is not fully clear. There are treatments available, and we have new drugs that are coming. Children can be cured, of course, and most of them recover completely. And when the disease is well controlled, children can have a normal life. Thank you.
Maybe we can move on to the next speaker that...
So good afternoon, everybody. Good afternoon or good morning, wherever you are in the world. It's a great pleasure to be here with you today, and I have to thank the Systemic GIA Foundation for creating this really important event. So okay, so Claudia already showed you an overview of the disease and how IL-1 and IL-6 inhibitors drastically change the outcome of the vast majority of our patients. But we know, and we heard it about in the history of the patients that spoke before us, that a percentage of patients experience a refractory course, more or less around 20%. So 1 patient out of 5 have a refractory course with a very wide heterogeneity of clinical presentation and severity. So what we call refractory disease, actually we don't have a unique, universally agreed definition of refractory course, but recently an international group of experts convened by the Systemic GIA Foundation identified 4 clinical phenotypes of refractory still disease course, which, as you can see, are slightly different. Some patients have a predominant arthritis, some patients have predominant systemic features, some has a refractory recurrent MAS, and some other the complication of lung involvement. Of course, there is an overlap between phenotypes, and one patient may present with different phenotypes together. The last 3 phenotypes are characterized often by very high levels of IL-18, and in the patient with refractory MAS, and also in some patient with lung disease, also with high level of interferon gamma. All these refractory courses are characterized by an inadequate response to standard treatment and requires long-term glucocorticoids to control the disease. So the recommendation that Claudia mentioned before, which were set by a group of experts, an international group of experts for the management of still disease, stated that regarding difficult to treat patients or refractory patients, the first statement is that refractory still disease patient should be managed in collaboration with a still disease expert center. So which are the treatment option when the standard treatment phase? So we already have heard a lot of histories and stories, and probably many of you are really experts about it. So I will not cover all the potential therapeutic strategies, of course, but I will try to focus on some medication that we believe that may be of interest to you. So your doctor may decide to combine different therapeutic and different medication with conventional DMARDs, like methotrexate, cyclosporin, mycophenolate, or combine different biologics, as we heard before. Or your doctor may decide to switch to off-label treatments. And I will briefly mention JAK inhibitors, himapalumab, and my NMAS 825. So the first drug I would like to talk to you about are JAK inhibitors. So some information for the ones that are not familiar with JAK inhibitors. They are an oral medication, and they do not target a specific cytokine as, for example, IL-1 or IL-6 inhibitor, but they dampen an intracellular signals, which is not specific to a single cytokine, but is shared among several cytokines. Some of them are inflammatory cytokines that are involved in the pathogenesis of steel disease, like IL-6. And here you can see interferon gamma, as Claudia said, is very important in the pathogenesis of MAS. But these intracellular signaling are also shared among some important molecules for us, like growth factors. So the objective, so the aim in the treatment using JAK inhibitors is not to block the JAK pathway completely. And we have different JAK inhibitors with different selectivity in the intracellular signal that they dampen. So JAK inhibitors are not approved yet for steel disease. There is an international multicenter clinical trial on baricitinib. We heard about that is still ongoing and is reaching its final enrolling weeks. So hopefully data will be available soon. Just to note that the dosage that is used in the trial, I have to say that for many of us, probably we noticed that for some patients with a very high activity, like refractory patients, sometimes this dosage was not enough. And the evidence on the use of JAK inhibitor in steel disease is built on several case reports and case series in refractory steel disease with different phenotypes. And there is an increasing off-label use in clinical practice, in particular for refractory steel disease patients with lung disease and recurrent MIS. We have to say that we still do not know whether there is a best JAK inhibitor on the other, and which are the phenotypes of steel disease that could benefit most from JAK inhibitors. The second medication I would like to talk to you about is imapalumab. As Claudia say, imapalumab has been a revolution in care of macrophage activation syndrome. Is a fully human monoclonal antibody anti-interferon gamma, which is the pivotal cytokine in the pathogenesis of MAS. As Claudia said, this is unfortunately not still approved in Europe. So in Europe, its use is still in compassionate use. This is the first trial that supported the approval of imapalumab in MAS, and it was a first pilot trial on 14 patients with MAS in steel disease with an inadequate response to high-dose glucocorticoids. And here, imapalumab showed a very good response with a rapid control of MAS episode and a significant reduction in the glucocorticoid use. More than 90% of patients in the trial achieved a remission of MAS symptoms by week 8. And imapalumab overall showed a very good safety profile and great efficacy. We have to say that often imapalumab requires a concomitant treatment with anakinra to control the underlying activity of steel disease. And results similar to the clinical trial have been shown in the real-life experience from the real HLH registry in the US. So US colleagues showed more than 80% of survival rate in patients with MAS. The last medication I would like to talk to you about, we already heard about it in the patient stories, is MAS825. MAS825 is surely a very interesting medication because it's a bispecific monoclonal antibody. So it can simultaneously inhibit both IL-1 and IL-18, which we saw are pivotal cytokines in the pathogenesis of steel disease and very important in patients with refractory disease. Again, MAS825 is not approved nor in US by FDA or in Europe, so its access is still in a compassionate use. We have an increasing evidence of MAS825 efficacy in refractory stale disease patients with different phenotypes, but especially in patients with lung disease and in patients with recurrent MAS. And there is an ongoing international multicenter clinical trial on MAS825, which is started in November 2025, so recently started. And the target will be the enrollment of 20 patients, and European sites are opening in the next week or months. Last mention for allogeneic hematopoietic stem cell transplantation. We heard about this in patient stories. Of course, transplantation is not a common option in stale disease patient, but may be considered in very severe patients which have failed multiple lines of treatment and which are severely dependent on glucocorticoids to control the disease. Here is the cohort of 13 patients which undergone hematopoietic stem cell transplantation in Cincinnati. All these patients had lung involvement. Of course, hematopoietic stem cell transplantation is a long journey, but 9 patients survived with and are still alive at 16 months of follow-up and had a complete response. This is the last slide, just to show you how, as a working party, we are actively working on different projects from different perspectives to optimize the treatment and to better understand the treatment for refractory patients. And with this slide, I have concluded, and of course, I'm happy to take questions if you have. I hope to have been in time. Sorry if I was long.
In the interest of time, maybe we'll move on to the next presentation, which answers some of the questions in the chat.
So, hello, my name is Vastert. I'm very pleased to speak today, and I'm very grateful to the Systemic JIA organization for taking the initiative for this event. And I'm also very pleased by the fact that so many patients and their representatives, their parents, are joining today. I'm just talking a couple of minutes on how to access expert care for Still's disease in Europe. I will set it on. I think it's now in presentation mode.
Yes.
Okay. So this is difficult, and I think I'm only going to speak for a couple of minutes and then leave room for discussion and questions. Still's disease and its complications are difficult to diagnose, also in expert centers. So you have to take that into account. But of course, some of the centers have more experience and more patients followed for this disease than other centers. So it definitely helps to contact if your child or if your disease is proven to be refractory, and if it's very difficult to get it under control. And in that situation, it may be very helpful to contact other physicians to think along with you. So I'm based in Utrecht, which is a city in the Netherlands, a small country. I've a long interest in systemic JIA and its complications. Important why I show this slide is that we are also the current chair of IRCCS, which is the European reference network dedicated to pediatric rheumatic diseases. So not only to Still's disease, but also to other pediatric rheumatic diseases. And therefore we are working on the organization and collaboration of experts in many diseases, but also in Still's disease throughout Europe and the rest of the world. I'm also chair of the clinical guideline committee of IRCCS, which is from one side developing guidelines on its own together with the scientific organizations, the press, for example, but also is endorsing existing guidelines for diseases in the pediatric rheumatology field. And in that sense, we endorsed the guideline that was published last year on the EULAR Press guideline on Still's disease, both in the pediatric and the adult spectrum, although this was developed under the courtesy of the EULAR and Press Scientific Organization. So what can you do if you feel your diagnosis is not under control and you are unsure whether your child or you are getting the treatment that could be most effective? As I said, this is a very challenging disease, and it's not uncommon. It's also a dynamic disease, so it's not uncommon that there are disease flares and there are complications of the disease. So the fact that they occur will not say that your doctor is no good or is not having the expertise to treat your disease. But it's always good to talk to your treating physician and the treating team. And at least from my experience, this should not be awkward at all. You can just freely discuss these kind of things. And that happens also with me and with my colleagues. And it's also completely normal in Europe to ask for a second opinion, to ask for a second advice. But then, of course, you have to know which could be a good center for a second opinion. And in this respect, often it's more easy within countries than outside of countries. So the European Committee has understood this, that there are disparities, differences between the different sides of Europe, east, west, south, north, in the expert of some of the diseases, and this can be really disease specific, so it's not always the same, of course. And they've set up an official system, the ARN-RITA CPMS program, which is specifically designed to get the help of international experts on judging the disease state of your child, of yourself, and also of suggesting potential treatment options. The problem here is that this is a really nice system, but it is really initiated. It should be initiated by your doctor. So you cannot do and enter and request it yourself directly, but you should discuss it with your doctor first, and your doctor can then ask for an expert advice via this program. More easily, of course, is to contact the Systemic JIA Mass Working Party of PRESS, of the Pediatric Rheumatology European Society. And we will put our emails in the chat. Claudia, Francesca, and me at least. Christoph is a translational researcher. He's not a physician himself, but Münster, the center where he's working, has really, really good physicians as well. And we are always happy to think along with you and to find a suitable center in your country, or if that does not exist, to at least identify a nearby center with expert or within the same language, because that's often helps as well, to help you further on this way. And even if that doesn't work, or if you do not dare to do so, you can of course also contact the Systemic JIA organization. We have been in contact via Rashmi a couple of times already with our working party and with some of the doctors to give a kind of a direction in a difficult situation. You have to realize that giving an advice from a paper or from an email or from an electronic file is different than getting an advice from when you see the patient yourself. So that is of course always a bit of a flaw in this advice, but at least it can be helpful. Here's a link below. I will also put it in the chat where you can find which hospitals are ARN-RITA member hospitals. And this is also a bit of a problem, because the ARN-RITA CPMS program is only accessible via its member hospitals. And currently, there are only 73 hospitals in Europe that are officially ARN-RITA members. And as I said, if you ask for an advice, then your treating physician is in the lead. He or she can, together with you, formulate your question and your problem clearly. And the program offers two kinds of advices. It will identify and approach several disease experts throughout Europe and sometimes even outside. And what is really good, you get a formal expert advice, which is covered by the European Union, so it will not cost you any money. And it can be twofold. It can be a written advice, just as an email or written advice. But it can also, your physician can also ask for a live meeting with experts to really lively discuss the challenge or the problem that you are encountering. And the system includes a secure upload of all of your patient healthcare records, information, and also of the imaging modalities. For example, if you have systemic GIA related lung disease, we can also then view your scans in a secure setting. So that's really an advantage. But there's also a disadvantage. It's only available via the 73 current ARM RITA members. So this is the current situation. I guess there might be questions.
I think someone had raised their hands to ask a question. Zoria, maybe? Feel like I saw a notification.
No, I just accidentally pressed the.
If I can just comment briefly, so this is a work in progress. I think the doctors will be able to give us more information about how to get help. My own son was very refractory. We needed expert opinions, and I definitely say that parents should also be proactive and ask their own rheumatologists for if expert help is needed, or or if not, then reach out themselves. This might differ a little bit from what the doctors are saying, but sometimes we have to do whatever we can for our children or ourselves. So I'm definitely, and as Dr. Vastert was just pointing out, if you are not being able to get help, write to us, post in the, let us know. We can also try to get help for you and connect you with one of them, though they are also giving their email addresses. So this is an important point for patients. Hopefully in the future we'll be able to come out with like a very structured process of help, but I think in the meantime we'll also post some resources. Dr. Vastert has put his email there, so that's valuable. Okay, so with that, any other questions? So now we can continue the discussions about, the referral process or an MAS 825, anything you have. And also, like, I would like to ask, ask us as a group, what are we hoping to accomplish here? What can we do to help, the foundation do to help, and what is our path forward? So please, anyone feel free to speak up. I think, Fabio, yesterday we were speaking and you had some great points if you want to share with the group.
Yeah, thanks, Rashmi. We shared last day just a few things about the association that you are going to be set up in Italy. And by the way, if the main goal is to find out a way to sit down with the EMA to let them listen our voices as patients. And I also discovered documents published by the website of EMA that based on their internal regulation, they have the responsibilities to organize events for patients that are going to use the experimental drugs. And I will send you the copy of these documents that I found out this morning just to share, because it's very important. It's a starting point of view, and that we can start to implement a group of high level in terms of not only from the emotional point of view, but also for a practical and administrative point. I think it's very important that the voice will be structured, will be followed by an association, by your foundation, by our foundation at global level and in every country. Have with a website rather than a group representatives of this still disease. These some thoughts that I've got in mind.
Sure. Thank you for sharing. What about from the physicians? What is your goal for us as a patient community? What can we do to help things along?
Surely to identify the initial steps involving the potential new people that want to apply, then they want to be involved in the new association, because I realized, and I'm sure it's not so simple sometimes to put a focus on something of only administration at the very beginning, without putting the focus on the emotional part of every one of us. And from your experience, maybe you can help us to find out also the right way how to involve the new potential people want to attend, they want to participate to this new association. Of course, we don't have experience on this, so very welcome any type of initiative that we can share first in Italy, and then of course our goal is also to involve a great part of the rest of Europe, because and available to find out how to set up this European group to be present at that famous table that I've got in my mind, where EMA and all patients can sit down.
Thank you. I invite any other patients or the physicians as well to speak up about what can be our goals as a group. Clearly, working with the EMA and helping advance new medicines is one goal. Claudia, what could we do as a group that would help all the research along?
So the patient support is very important for us. First, because we need to know what you need from us. So difficult to explain, but your support is important to understand what you need from our side. Because we probably follow our way, but could be different from your point of view. So work together is very important to follow the same way.
Okay. I do think that from what I'm hearing, I think a more information about how patients should get help is probably something important that we should jointly work on and make it accessible to patients. That's something that we worked on many years in the US, and we'd love to work with you on that. I see somebody has raised their hand.
Yes, this is Luciano Vitiche from Italy. I am the father of Brisa. We have had this experience during last years. I do apologize about my English, but I guess I could share an idea together with you. Maybe it is not so important, but I would like to share. I guess that we as parents of patients of this disease, we could share information about the early symptoms we experience on our children, no? When they are going to be sick. So maybe we can pass those informations to the doctors and to the research people, in order to give to them further information that are not just the information that they can recognize into the blood of our children, but those information can or at least should help further children to be on the right track sooner, you know. So maybe I will try to write down this idea into a kind of paper to share together with you, in order to maybe start a collection of information along all of us in order to collect information that may be useful, maybe not, but at least we will try to do something actively.
Thank you so much for sharing. Any other thoughts or comments?
Can I just say something? Sorry, I just wanted to say how useful it is to get everybody from Europe sort of together in a space. I think, you know, for a long time, the way that the US works compared to Europe is such a huge contrast. And although, you know, as a parent in the UK, I found the foundation to be invaluable because of that deep loneliness that you go through as a parent when your children are first diagnosed and you're going through very, very dark times. It has been wonderful, but this is so encouraging for me to have people together from Europe, and the information that Bas just gave out about second opinions, and because that can be very daunting as a parent. It feels like you're not trusting your physician to go and ask for a second opinion, and that can be very difficult. So I've, you know, even though I got a second opinion, I found that very useful, because I think, especially as Brits, you know, we're very polite and we don't like to challenge. So you know, or most of us are, me not so much, but you know, most of us are, and I find this today just it's really heartwarming, and especially because the foundation's been so involved in the States and kind of further afield. It's lovely to be together with, you know, with people from Europe who have a similar system going on. So I just really wanted to put that out there.
Yes, thank you so much for saying that. We did realize that we needed to do things. I mean, the geography is, as you're pointing out, is different enough, and the rules are different enough that we need to be paying specific attention, and we plan to do that. From our side, some of the things that we are planning is that we will definitely have follow-up events like this in a few months and have different themes so that we can have different focuses. And we promise to do a better job for adult patients next time. Then we are planning to set up a patients council for Europe, kind of from many different countries, so that we have representation from different countries for the foundation, and we can, you know, have that when we go out to talk to the EMA or anything like that. I'm also heartened. I've discussed this with a few times with Dr. Bracaglia and Dr. Vastert. If we can actually do an event in Europe. We've done several events in the US, and it's always been for me a little bit scary to organize in a place I don't know. But I think with all of your help, given how many people there are, maybe it's time to plan that. So I'm excited about that. So I also plan to spend some time in Europe this summer, and I'm happy to visit any center and work with the doctors there. So putting that out there. So some of the things we are thinking about how we work better in Europe. If people have suggestions, it's a good time. We'll take a few extra minutes if you have any suggestions for us.
I think it's also important to mention about the press conference. So anyone who feels like the patient who feels like going to the conference, I do encourage you going. It's for free. Like if you cannot go in person, you can also register. Just ask a letter from your doctor, and you can register and attend the conference online. And it's very interesting to see how the doctors are connected and how it works, how research works. So I do encourage everyone to attend at least once the press. And sometimes it's in different countries. Each year is in a different country, so probably will be close to some of you next year.
Yeah, we will be there as well with the booth this time. We will be there. Well, in that case, we will be sending up a follow-up to this event. So for everyone who had registered, the video is being recorded, correct, Luciana?
Yes.
So we will share that. We will share some of the links that you saw in the chat posted today. And we've shared our emails and we'll send that in the follow-up email as well. Feel free to reach us anytime. A lot of our knowledge and understanding actually comes from the individual interactions with patients. So we really welcome that. And we'll figure out, I think, probably set up a WhatsApp group for Europe, etc. So we'll be doing some things on our end and you'll be hearing from us. And once again, thank you so much for joining. This has been so many people have shown up that it's amazing. It's very encouraging, and we'll be moving forward with this. Thank you.
Thank you. Thank you, everyone.
Bye.
Thank you. Bye.
Bye-bye.
Thank you. Thank you, Rashmi.
Thank you. Bye-bye. Thank
Yes,
you.
Luciana.
Have a good day.
Thank you. Bye.